Welcome, everyone. I'm Lisa Graves. I'm currently I am the AFMC project lead for the AFMC's response to the opioid crisis. We want to welcome you to our first webinar series to supporting a community of practice. I wanted to take this opportunity to give a few words of introduction. I want to acknowledge that this project is made possible through a financial contribution from Health Canada. The views expressed herein do not necessarily represent the view of Health Canada. This project would not have been possible without a wonderful program planning committee. The members of this committee are listed here, and a huge thank you to each member for their contributions in making this series of webinars possible. We've listed here an extensive list of any community disclosures from the Planning Committee for your interest and review. It's really important as we think about this to remember that this presentation is part of an initiative of continuing professional development. It aims to provide information and opinion which will assist physicians and other health professionals in maintaining and enhancing their competence. All content provided in this presentation is intended to be used thoughtfully. Viewers of the presentation should rely on their own professional skill and judgment to assess the accuracy of the opinions and the information expressed. A few other bits of information that may be helpful. There is live transcription available for the session. We're going to be using the question and answer function located in your toolbar for questions. We are recording this session, and we'll make that available to individuals who would like to be able to look at that. You will get a post-program survey, and certificates will be made available for the series on October 3rd, 2022. So this is the least exciting part of the webinar. I am very excited that we have two presenters today. Eugenia Oviedo-Yocas is a PhD professor and the Canada Research Chair in Person-Centered Care in Addiction and Public Health, School of Population and Public Health at the University of British Columbia, Center of Health Evaluation and Outcome Sciences in Vancouver, British Columbia. And Scott McDonald is a physician and the physician lead of the Providence Crosstown Clinic in Vancouver. They both come with a wealth of expertise in this area. I'm looking forward to their presentation, and I hope you will enjoy this as much as I think you will. Over to the two of you to lead us through a discussion, and I will stop sharing my screen so we can see your slides.
Thank you so much for the wonderful introduction. Can everybody see our slides? Yes. I will take Dr. Scott saying yes as a yes. You can see our slides. Dr. Scott, would you like to start saying hello?
Well, hello, everyone. Thank you for coming to this presentation. Today, we're going to talk about injectable opioid agonist treatment, or iOAT, which is relatively new here in Canada, but expanding and has a much longer history in other parts of the world, particularly in Europe.
Thank you. Thank you for that wonderful introduction and calling our work exciting. So we really hope that we can pass that excitement that we have. Let me try to go ahead in the slides. Yes. Before we can start with our presentation, we would like to acknowledge the land we reside today. I am particularly a visitor and invited from the unceded territory of the Squamish people. I was born in Argentina. The land of my ancestral people are the Comechingones and Sanavirones, and I'm a Latina woman, and I will pass it to Dr. Scott to make his acknowledgement.
Yes, and I also am grateful to be living, working, and playing on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So grateful.
Thank you. Other acknowledgements, we would love to have always and never underestimate that everything we are doing is for our study participants when we talk about research and clients when we're talking about specific things about clinical care that Dr. Scott mostly will say. The frontline workers across Sun Clinic and other iOAT partner sites, and the research team that is the people that collects the data and work with us. We have nothing to disclose. Briefly going through the presentation objectives, we will hope that we can get through these 4 main objectives at the end of the session to distinguish the currently acceptable drugs of injectable opioid agonist treatment in Canada, recognize person-centered care principles for people receiving iOAT, discuss the role of individualized treatment in iOAT and continuation of care, and talking about continuation of care as an overall picture, and identify and discuss person-centered care outcome measures. We wanted to bring this particular point as a way to see how we look at people and how they are doing on treatment. So just to open a bit of why this topic is so timely still, and not for because the people listening doesn't know this yet, but certainly the problem of the toxic drug supply is not yet addressed. We do know that in Canada and the US, the overdose deaths from fentanyl and analog drugs have increased or not changed. This is really worrisome. There is a lot has been done, but this has not changed and getting worse. Interventions have expanded across parts of Canada. Like, supervised consumption sites are started to be opening. Also, overdose prevention sites and naloxone distribution has been expanded greatly. Together with opioid agonist treatment, it is estimated that these interventions have saved many lives. But iOAT, that has proven to be safe and effective, has been expanding slowly. Overdose deaths attributable to prescription opioids, and we do understand that they play a role, have not decreased proportionally to the decrease in dispensing. And there is important data from the US where the number of outpatient opioid analgesic prescription dropped 13% nationally, but this rate does not seem to go in parallel with the overdose death. Dr. Scott, would you like to speak about background and keep going?
So this is just some background on opioid use disorder and that it is a chronic relapsing disease. We have some good treatments. An oral agonist treatment with long-acting opioids like methadone, buprenorphine, sustained release, oral morphine work for many people, but they do not work for everyone, nor do they work all the time. There's evidence now from Canada as well as European studies indicating that medically prescribed injectable options, both diacetylmorphine, which is the active ingredient in heroin, and hydromorphone, are both effective, feasible, and safe treatment options. No single treatment is effective for all individuals. We need diverse options and not just more, also more medication options as well as other approaches. So this is a slide adapted from Professor Wim van den Brink in the Netherlands, who led injectable opioid agonist treatment trials there a couple of decades ago. And he describes a range of approaches from a goal of abstinence to a goal of harm reduction. And it's possible, perhaps, for a clinician to meet a patient along this continuum and acknowledging their goals and where they are at their point in care. And along this goal, it really is, people can move along this continuum in and out of relapse or being abstinent or being on appropriate medication or using street or illicit opioids. And the patient's goals might be abstinence. It might be a life without opioids. But many of the patients that we see are currently seeking a life with a safe opioid high, or maybe just life without withdrawal. This may be the patient perspective. And I think as prescribers or as clinicians, we can meet these patients where they are if we had access to the full continuum of care options. Many of the current options we have are closer to the abstinence side of this continuum. And the options that we have here in Vancouver, such as injectable diacetylmorphine, that may be life without withdrawal for some of my patients, but for others, they feel a euphoric effect or some benefit from that keeps them in care, keeps them engaged, and separates them from the illicit stream of opioids. So what is the evidence for diacetylmorphine? Well, there's a century of diacetylmorphine evidence and experience in the UK, where they've had a take-home model for going on a century. But in the late 1980s, Switzerland sort of identified that, well, we have methadone, it works for some folks, but we have a public disorder problem with public use of heroin, and we need to try something else. So the Swiss began the supervised model, different than the United Kingdom model, in the early 1990s. Since then, this has been expanded into several countries, including the Canadian Naomi trial, which ran with sites in Montreal and Vancouver in this clinic where I am sitting today. The Naomi study, the Canadian trial, asked the question, is diacetylmorphine superior to methadone in a population that continues to inject illicit opioids despite attempts at the standard treatments like methadone? And yes, it is superior, and that contributed to this Cochrane review, which was published in 2012. There's 8 randomized controlled trials involving over 2,000 patients, and when all those studies are pooled and compared, heroin provision under any condition, it remains more effective. The effect is in favor of heroin in that population. Now, adverse events are more frequent, and we recommended the supervised model, but most of those events can be mitigated and managed in the supervised setting, and most common things are histamine-like skin reactions, for example. Retention is better. Reduced street use is better, illicit activities reduced, and possibly mortality from the Cochrane review. We have subsequent data showing, yes, in this population, there is reduction in mortality. And finally, the patient profile. This is for those folks who are not benefiting or continue to use the street heroin, whether they're retained in treatment or not, compared to oral treatments. Now, our Naomi study, the study that ran from 2005 to 2008, unfortunately, we weren't able to transition to a program. There were just too many barriers. It wasn't possible at that time. But it did lead to our follow-up study, Salome. And thanks to Dr. Henya Ubeda-Yokis for her amazing academic work and getting that funded and the study done and the studies into the literature. It was key to a program that we have today. Who would have access to this? And this is the participants' profile or the eligibility criteria. And people had to meet opioid dependence as confirmed by DSM-4 criteria at that time. They had to be at least 19, at least 5 years of opioid use, regularly injecting opioids in the past year, at least 2 episodes of opioid addiction treatment, and including 1 or more episodes of substitution treatment, which could be Suboxone or methadone, for example, as well as poor physical, psychological, mental, or psychosocial functioning. Using this criteria, we selected folks who on average had had 15 years of injection experience and on average 11 treatment attempts. So this criteria is truly too rigid. We need to get people in earlier. We need to be more flexible, and it's probably a switch from asking about eligibility to how do we attract people into care? How do we get people into the door and into the clinics and into the healthcare system? So this is just a quote from one of our Salome participants, and thanks to Kirsten Marchand, who has completed her PhD and did some work, some very outstanding work in patient-centered care in the iOAT population. And this patient is probably the most important thing about iOAT would be the medication, because that stops the need for other things, not needing to go and buy street drugs, not having to go and do crime. Like I said, I always had charges. I was in and out of jail all the time. So this is one slide from the Salome study, which randomized 202 people to either hydromorphone or diacetylmorphine. And then we were followed for 6 months. This is number of days of accessing street opioid use in the prior month versus time over 6 months. And when people start, they were accessing street opioids multiple times a day, virtually every day in the last month. 6 months in care, that goes down to a handful of days. So it's just a snapshot slide that illustrates how effective iOAT can be at separating people from the poison street supply when they have access to the care that they need, when other options have not been effective. Again, this is diacetylmorphine and versus hydromorphone, and its mean daily dose prescribed and received. Hydromorphone is about twice as potent as diacetylmorphine gram for gram, but in this graph it's expressed as diacetylmorphine equivalents. And the solid line is hydromorphone or diacetylmorphine prescribed, and the dotted line below in green or blue is either hydromorphone or diacetylmorphine received, over the 6-month treatment period. And I think many prescribers should find this reassuring. In the induction phase, and while we're adjusting the dose, the amount prescribed increases over the first few weeks, but then it settles out. People do not continue to escalate their doses. People reach an effective dose and stay there. And in fact, people even take less than prescribed. And from a patient-centered perspective, we don't need to police these doses. People can sort out between them and the nurse who's supervising what dose is effective for them. If they want more, as long as they're tolerating it, they can have it. That's a patient-centered model. It's individualized, and there's supervision. There's a nurse there to make sure that it's safe. And this is from our cost effectiveness analysis. And thanks to Nick Bansback, who was the health economist who did this analysis using pooled Naomi and Salome data. From this analysis, we can say that both diacetylmorphine and hydromorphone are more cost-effective than continuing methadone in that population that continues to inject illicit opioids. And using quality-adjusted life years and ICERs, those ratios, they're able to model and show that there's an approximate savings of about $140,000 over a lifetime per person who had access to diacetylmorphine or hydromorphone rather than just continuing methadone. Additionally, he was able to show that there is a reduction in mortality and a reduction in crime, both property crime and violent crime. And providing diacetylmorphine or hydromorphone, those models suggest would reduce crime rates by about 6 rather than continuing methadone alone. 9 in the iOAT arm versus 15 in those who are receiving methadone.
So thank you, Dr. Scott, for running through the evidence. With this slide that we have here, we want to see how is currently iOAT being offered or being delivered to the clients. Overall, mostly in Europe, as Dr. Scott was presenting, is the medication is dispensed and self-administered by injection under the observation of nurses or other qualified personnel daily. This means the clients come to the site 1, 2, 3 times per day. Some places in Europe, they might be allowed even to come up to 11 times per day. They have other rules on how their sites function, but they will have to come daily. The observation intends to ensure the safety of the clients, as Dr. Scott was saying, to see those intolerances. We want the clients to feel safe, and the community, because sometimes having these potent medications outside the site, they might be exposed to victimization of the clients, or also, others being exposed to those intolerances. The most important part for us, for those who have been working in iOAT for many, many, many years, is that for some, injectable diacetylmorphine or hydromorphone seems to provide enough motivation to attend and engage into care routinely. These medications and the way it's provided seems to have enough for them to come. These daily visits allow the nurses, the staff, and the clients to build and maintain relationships. And this approach to care provides this tremendous opportunity to offer comprehensive care and connect people with services. Dr. Scott, maybe you want to tell us a bit about Providence Healthcare Crosstown Clinic.
So this is sort of a snapshot of the patients that we and our program. We've been a program post the Salome study since 2014. Today we have about 95 clients who will be coming in for injectable treatment options. Our numbers are down a bit due to the COVID pandemic. There were many months when we were our priority was reducing congestion at the clinic, and we weren't taking new patients. But today we have about 8 who will be receiving hydromorphone and 87 people who will be receiving diacetylmorphine. About 70% of our patients also take a longer acting opioid. This is to bridge overnight or between doses. That can be small methadone, mostly long acting morphine formulations. But also we've recently started using fentanyl patch, transdermal patch. We have a number of folks who have transitioned on to non-iOAT treatment options and continue at the clinic, which is about 28 folks, also people who have transitioned to other clinics. But many of our folks, this has sort of become their medical home, maybe the only clinic they found that they trust, and we will continue to follow them at the clinic. About 30% of our patients identify as Indigenous. That's the Vancouver and British Columbia experience. We think they do just as well in care as other folks, but sadly, compared to the general population, this is overrepresented. And we're glad that we're able to engage those folks in care. Our clinic is mostly male, about 72% male. And our crosstown team includes nurses, physicians, a nurse practitioner, a dietitian, social workers, clinical assistants. We do some outreach to assist folks, and we have somebody who screens for COVID symptoms at the door. Just to show that this does take a team.
Thank you. And this is just a quick slide if we're trying to think about what are the medications that right now are somehow available in Canada. Hydromorphone has been licensed for opioid use disorder under the supervised model of care, as they call it in the Sandoz brochure. And diacetylmorphine right now is only available in a handful, not even a handful, a few clinics. And, Dr. Scott, would you like to speak a bit about how much progress we're making with diacetylmorphine?
Well, let me just start by first saying thanks Health Canada that we have approval and an indication for hydromorphone for treatment of opioid use disorder in the supervised model. That's been key to implementation of iOAT in the provinces where it is currently available. It just has lowered the threshold and made it seem possible where it hadn't been before. And I'm glad to see that there's iOAT with hydromorphone is available from coast to coast now, from British Columbia to New Brunswick. Maybe not every province in between, but at least half the provinces have access in a small way to hydromorphone. Diacetylmorphine has some particular challenges. It's not available outside of the lower mainland of British Columbia at this time, but it's certainly much easier to import and get now. And again, that's thanks to Health Canada. And when we started, I used to have to do individual applications every 3 months for each patient. It was quite onerous, but now the Canada Public Health Officer can sign off for importation, and it's really done automatically now, and we have it available. I anticipate in my conversations with the Ministry of Health here in BC that we will have a domestic supplier of diacetylmorphine sometime early in 2022. We don't know the formulation yet, but I'm confident that there will be a domestic supplier. From my wish list, I don't think we have the perfect product at this point. Diacetylmorphine comes currently as a 10-gram vial, and then it needs to be compounded in a NAPRA-compliant facility. We can certainly manage that in a large urban center like Vancouver, but if this is going to be, or iOAT and diacetylmorphine is going to be available in rural and remote areas, this is going to present a number of challenges. So perhaps we'll have higher concentrations, perhaps we will have lower amount vials that might be more amenable, or maybe even we'll have preloaded syringes. This waits to be seen.
And now moving a bit from the formulations and the medication that Dr. Scott were discussing, and what is our approach to the medication? And this is something that we constantly see, particularly in injectable opioid agonist treatment, but it's not only on iOAT. We see this constantly when we try to approach the care of people that require medically assisted treatment with opioids. Either we go to an over-reliance on the medications, and that's all we offer, and everything, all our dots are riding on the medication, or this restricted access to medications. When this over-reliance occurs, the system that incentivizes this quick, simplistic answer to complex physical and mental health needs. We cannot expect this molecule, this simple change of chemical reactions that I will show you in the prior slide, to go and fix years, decades, and sometimes generations of inequities and pain of physical or mental or structural vulnerabilities, as too much riding on a molecule. At the same time, restricting access to medications is one-dimensional measure that are not feasible solution to such a multidimensional societal problem. How we provide the medication matters. People are forced into the illicit stream of drugs because they can't get legal access to meet their needs. We have a treatment or various treatments that actually work. If we are forcing people to meet the needs of the system, even the most effective treatment is meant to fail. With a person-centered care approach, we're trying to honor clients' preferences in the medication they will choose to take, the setting, and the format of the treatment. These are sometimes limited by the restrictive regulatory systems, structural vulnerabilities, and lack of providers training in PCC. These are actually my hands holding the medication. Yes, I didn't go to jail holding 10 grams of heroin in my hands. So an exclusive focus on the medications, as I was shown in the prior slides, either by relying solely on the medication or restricting the medication, either the side of the component impedes an effective response. There are very complex interconnections. I'm not saying anything new. I just want everybody to remember that in this approach too, we have to maintain this flexibility. There is complex interactions between the use of the substance and maybe obesity, disability, chronic pain, depression. And we have not explored them adequately, particularly because there is a lot of stigma on this population and on this subject matter. Also, we have macro systems that are coming to play. Again, I'm not saying something new. I just want all of us to maintain this position, this big picture, and not ask this humble molecule to do it all for the client. And then the client just meet the needs of the system and the regulations and come and do all this when this is just a molecule and there's so many things that we have to consider. Let's not forget the high rate of incarceration that creates further disparities among individuals and communities. When we think about person-centered care in addictions, there are some common principles about PCC, person-centered care in medicine, that we wanna apply in addiction research and addiction care. But it seems to be quite hard to bring them home, bring into this field. It seems that we are getting there in other areas of medicine, but when we think about addictions, what do you mean share the decision about the medication? Those concepts about sharing the decision about how an opioid has to be prescribed, it seems not to sit well with the entire community. So we want to share the power and responsibility between the client and the healthcare provider when we are making a decision. Better communication, information. Is there a place to discuss how the dose is going to go? As Dr. Scott was saying, clients know where they want to be. Can we have a shared decision making, not just across time? An individualized approach by focusing on the client's unique goals, the needs and the preferences with an understanding of the whole person. Every person comes to treatment with their self-identified goals. And the system, and sometimes the providers, because the providers are also handcuffed many times by the rules of the system, might have other goals. And how can we work with that? And the emphasis in the quality of the therapeutic relationship with the providers. That is key for person-centered care. And we do understand that many times the turnover of the staff, the lack of resources, the uncertainty of the world we live in doesn't leave too much space to work on this key aspect of person-centered care in addictions. On the many years that we have worked on injectable opioid treatment with Dr. Scott and many others, we have always known that people come because of the medication. As the quote that Dr. Scott brought up, people come because of the medication. There is no other treatment with an oral, long-lasting opioid that is going to make people to come 3 times per day. We do know that. The point being here is they don't stay just because of the medication. There is much more that needs to happen to support a person when there is so many other needs that needs to be met and so many other services that needs to be connected. So, for example, in this slide that I'm showing, as you can see, we put the medication here halfway. But let's look at, for example, intersectionality. Let's think about geography. Let's think about bringing this treatment to other parts of Canada. Let's think about this observational model where people have to come 3 times per day. Is there a place to provide this treatment in a way that people can take the medication with them in places there is no way they will be able to come 3 times per day? Person-centered care will allow this therapeutic relationship to grow to a point where the person should be able to take the medication with them. Dr. Scott, there is anything we would like to say about this iOAT in the continuum of care?
Well, maybe if I could just give an example of individualized care, we have a patient who's starting today with us, who was recently admitted and just discharged from hospital today, and the St. Paul's Hospital here in Vancouver, in order to assure that he would have his infection managed, started him on injectable opiate agonist treatment with hydromorphone in hospital. He was to be discharged today, but had never been to our clinic and doesn't have housing. So we have an outreach worker who was able to go and meet him at the hospital and take a taxi here with him in order to build that first step of trust that we could go and seek him, invite him to our space, and sort of a warm handover, if you will. He does not have shelter, so if we didn't have that connection and without shelter or place to stay, he was able to come in, get started, and connect with our social worker and try to make those bridges. Did we talk about future planning? So many,
please.
Many people will transition on to other things, and it's not easy to come to this clinic 2 or 3 times a day, especially when people start reconnecting with families and working and going to school. So also, obviously, we always support people to transition onto less onerous treatments when they're ready, and that's the right thing to do. But many folks will not have relationship with other clinics, and we could have a system that supports people to move on. That there is a warm handover, and then there's outreach. But for some people, this may be a lifelong treatment, and that plan for that as well. Because if this is effective and it's what people need, and they're on it long term, that's fine as well.
We want to ask to bring put the thought about person-centered care, person-centered outcome assessment. And the reason we wanted to bring this is we cannot continue assessing our setting our treatments just from the system perspective. We keep looking at retention in treatment only and adherence. We keep looking at urine screens and looking at mostly abstinence oriented because that's what it gives you, a yes or a no. The urine screens tests do not give you a sense of, oh, I'm using less today. I used to use 20 times per day, and I use now 10. The overall stability, quality of life, and psychosocial health is something that sometimes we can look also into, that is not just from the perspective of the system. I wanted to also bring an example about retention in treatment. These are two different graphs. We have buprenorphine and methadone. This was on a clinical trial that actually helped to market buprenorphine in the US. And after 3 months, there was a 60% retention. And from the perspective of the system, that was great retention. So one of the things that we think about when we look at that graph is what happened with the other 40% of the clients. When we think about where did they go? What is the transition? If we are thinking that, methadone and buprenorphine are the only 2 medications available, what happened with the person? How many days? What happened every day? This is a system level outcome. In the other side, you can see the curve after 20 years, of course, of injectable opioid agonist treatment. That will be, they don't have hydromorphone in Switzerland, they only have diacetylmorphine. And of course, in the first year, they have 80% retention, a very high retention injectables. But at the same time, people over the years are going to start transitioning to other treatments. So when we look just at retention and people being or not being on treatment, there is a lot of nuances on what happened to the person that we cannot see. This data is important to collect, but cannot be the only data we collect to look at how the person is doing. And we are advocating to also collect and look at other outcomes. And we want to consider the self-identified goals and the priorities and what is meant by successful intervention from the perspective of the participant, from the perspective of the client. Sometimes when we look at this and what the client said, these 2 pictures might not agree. And these disagreements are okay. Not because we can say, well, the retention is very good. From the system perspective, a 60% retention is a good retention. But from the perspective of the clients, some things might not be working in the same way, or they might have a different perspective. And we need to be working towards adding what is relevant for the client, what is the outcomes that they feel, how is this improving my quality of life? And those numbers are small. Those numbers are nuances. Sometimes it's qualitative narratives. Sometimes are going to be 30, n equal 30, that you cannot really make a nice plot out of it. But we need to start collecting what is successful from the perspective of the client. And this will be our last slide. We are closing our presentation here, and we don't have any conclusion because we are not concluding anything. We wanted to say moving ahead, and moving ahead. I will just, Dr. Scott wanted to highlight the maybe the first 2.
So injectable opioid agonist treatment is just another tool in the toolkit. It is both treatment and safer supply. One more tool. We ideally will see expansion of injectable opioid agonist treatment, but not just the medication. An integrated care approach is required. We need to care for the people that we see, which needs to be comprehensive, not just meet their opioid and substance use needs.
Thank you. Certainly, we need more person-centered care in addictions, not only in iOAT, and we need to offer iOAT in the way that people want to receive it. We can't just stay in a very, structured way, because in that way, only very, very few folks are going to access it, as that slide that Dr. Scott showed on that inclusion criteria. We need to continue progressing towards more person-centered care and offer iron in the way that people want to receive it. And other countries are offering integrated iron and other formulations. Like we need to just keep disrupting and keep thinking, how can it be that we are only offering two molecules, injectable DAM, injectable hydromorphone? We do know, we have evidence for inhalable morphine. We should be offering orals. Clients and providers want this flexibility to be able to serve the patient, clients in a way they want to be treated. So thank you very much. I will stop sharing my screen.
Thank you so much for getting this started. And thank you so much to some of our participants who've already started to put some questions into the Q&A section. I'm going to read the first couple of questions because I think they all are looking for the same sort of answer. What is your response to the iOAT literature being applied to safer supply take-home tablet programs by Health Canada and justification for funding safer supply? And then flowing from that, what outcomes do you think we should be looking for if safer supply tablet programs? What population outcomes in addition to client-specific outcomes? And there's a little bit about patient-centeredness, but maybe we'll sort of toss those two questions out first, and then deal with the next two questions that have come up.
So if I could start there, I'm certainly grateful that there's more options available today. Specifically about iOAT, both hydromorphone and diacetylmorphine are supported by a tremendous amount of literature and evidence, and in my view should be expanded, and that evidence could inform funding decisions across the country. To date, those decisions have not been made. That is a value-based decision. If something's more effective and more cost-effective, it should be made available. If it's not been made available, then the barrier is something else. It's certainly not evidence. And then outcomes. Well, for many of the folks that we see, it's not going to be abstinence. So we need to find, as Dr. Hubeda-Yocas discussed, we need to find patient-centered outcome measures. And that's more work, but that's work that needs to be done.
Thank you. And then on the same veins, persons with lived experience would say that self-titration of tablets at home is more client-centered than observed dosing. What's your response? And then really following through in terms of motivation to attend clinic daily, how can iOAT be implemented in areas where safer supply tablet programs are active and which provide several days of take-home doses?
So again, this is one more tool in the toolkit. And I'm not going to criticize tablet programs, and they're working for some people. But if they're not working, if the amount that is prescribed isn't meeting somebody's needs, then perhaps they need a higher dose and an option that just cannot be met with prescribed oral tablets. There is extensive evidence that iOAT might be effective. Is it onerous to come 2 or 3 times a day? Yes, but we have evidence that providing that injectable drug at doses that are effective for patients is enough incentive to attract people into care.
And then just to follow up on that, the coming to treat or coming to the site, it's also not always something that service providers want to happen. It's also a regulation that is very, very hard to change when we try to provide carries, and not just carries for injectable, carries for oral too. It's hard for me to speak about the tablets because the written evidence It's not that much available, and the individual experience of the clients are absolutely valid. And if something works for somebody, they should keep doing it. And more is always better. I can only speak about what is that we know about iOAT. And if we want to break, and as I was saying in the example, it is imperative that a medication and a solution that we know works for clients allows to be expanded. But there are a lot of regulatory barriers that do not let it be, and the price and everything adds to the cost. So this is something we know works. We know this is something that we know is benefiting clients, and we are advocating to expand it with a person-centered care approach. That means also take homes.
Great. And a couple of very practical questions. Is this IV, SQ, or IM? And what do you do if a patient builds up tolerance?
So IV or IM, yes. Most of our patients might be seeking to inject into veins, but they may also inject intramuscularly. Some people may have lost their venous access or have difficulty on occasion to inject intramuscularly. Our nurses are able to provide an intramuscular dose if somebody's unable to self-administer. And subcutaneous is also an option. And just a quick analogy, we had somebody who was going into palliative care and was on hydromorphone with us. But in palliative care, they weren't ready to support IV or intramuscular treatment. However, their dose of hydromorphone was 100 milligrams, which is 2 mils, which is an amount that's routinely used in palliative care. So the hospice was more than happy to administer 100 milligrams of hydromorphone solution sub-Q, but wasn't ready to do IV or IM. So all of these are options.
And what do you do when the patient builds up tolerance to iOAT was the second part of that question.
I think all of our patients have tolerance, and that's sort of the goal. We want to get them to a safe dose that they tolerate. If the question is, do some people wind up in a dose that's not effective or the drug's not working for them? I have not seen sort of the hyperinduced analgesia. Have I had a couple of patients who were on diacetylmorphine or hydromorphone doses and it wasn't really working? Yes, but then we would just switch them and try another drug. Isn't it great that at CrossCenter in BC we have two options? If hydromorphone is not working, well, we can try diacetylmorphine or vice versa.
Thank you so much for those answers. I'm not seeing any more questions appearing at this point in time in the question and answer. So I will take this opportunity, first of all, to apologize for not reminding us as we started to be mindful of the land on which we are sitting and from which we are presenting, as that varies for each one of you depending on where you're sitting at this time. I wanted to also take this opportunity to thank Dr. Oviedo Yocas and Dr. McDonald for an excellent presentation and really getting us thinking thoughtfully about iOAT as an option for treatment of opioid use disorder. I want to thank those of you who are participating for some really great questions that I think were wonderful in that you asked the questions that everyone else was thinking, and I thank you for bringing those questions to the forefront. And with that, I'd like to conclude our first webinar in our Community of Practice series. Thanks to all of you for joining, and we look forward to seeing you at our next presentation date. So thank you very much, everyone.